When I first found out about Profound, and I was reading the CAPTAIN trial, but essentially the CAPTAIN trial showed really good perioperative results, so zero blood loss, reduced pain, shorter recovery, better function scores compared to, let's say, robotic prostatectomy.
You're right, the urethra applicator or probe is placed through the penis up into the bladder, so it's just using natural holes for delivering the treatment, and as a result, the recovery tends to be quick. These are done as an outpatient procedure, so patients get this done and are able to go home on the same day. So fairly quick recovery process, which is great.
You can't replace part of the brain. Like,
you treat them the same.
Source of truth for the MedTech industry.
Coexists with the prophets.
Robot understands things automatically.
Number one show in the MedTech industry.
So Stryker got ahead of that and changed in the $90 billion company. They had help up high, a lot of things.
State of MedTech with your host, Omar Khateeb.
Hey everybody, welcome back to the show. As we kind of round out Prostate Awareness Month, we looked at a lot of really cool technologies, one of them being the Tulsa procedure from Profound Medical. You saw their new patient advocate and ambassador, Leonard Wheeler, come on to talk about his story. This time we have a clinician who's going to talk about how he uses the technology in his practice and also how he came across it. We are joined by Dr. Geoffrey Sonn, who's Associate Professor of Urology over at Stanford Medicine. Dr. Sonn, thank you so much for joining us. How are you doing today?
I'm doing great. Thanks for having me.
Awesome. Well, I mean, before we talk shop and get into the technology, maybe for those listeners who are just learning about you, give us a little background. Like, first, like, where did you grow up? How did you pick medicine as a track and a career? And then where did you do your training?
Yeah, thanks for asking. I grew up in Washington State. I was there until I left for college. I went to Georgetown for college and then went to UCLA for medical school. I spent 4 years in medical school at UCLA. Then I did my urology residency at Stanford, which was 6 years, mostly clinical, 1 year of research. And then I went back to UCLA for a 2-year urologic oncology fellowship, so focusing on urologic cancers, prostate cancer, kidney cancer, bladder cancer, et cetera. And then I moved back up to Stanford for my first job coming out of training, and I've been here ever since. So I've been at Stanford for 12 years now, and I primarily specialize in prostate cancer and kidney cancer care.
Fantastic. You know, while you're in fellowship, I guess back then, like, what were some technologies and I guess techniques and procedures that really attracted you?
Probably the reason I got my job at Stanford is I glommed on to Dr. Lenny Marks, who was at UCLA at the time in the very early days of fusion targeted prostate biopsy. And that's a technology that was new then, where an MRI would be lined up with an ultrasound during the time of a prostate biopsy, and it greatly improved the accuracy of diagnosing and detecting prostate cancer. So when I got my job here, I pitched that technology as something that I could bring to Stanford, and I've continued to do that here. That was, again, new at the time and is now very widespread and clearly improves our ability to detect prostate cancer as well as to help reduce the number of men who need a biopsy. So men who have an MRI that's normal often can avoid an invasive biopsy in the first place. So that was the technology that I spent most time on in fellowship. I saw a little bit of what we call focal therapy, which is a method of treating prostate cancer. But most of my experience in focal therapy has really come since coming to Stanford, and that field has grown quite a bit over the last 5 to 10 years.
The focal therapy, that's mainly like ultrasound based, I believe, right?
Focal therapy is just the general idea in contrast to the more conventional treatments for prostate cancer, where we'll either do with robotic surgery and remove the entire prostate or doing radiation to radiate the entire prostate. Focal therapy is the idea of, well, let's just destroy a portion of the prostate where cancer may be present. So now as imaging and image-guided biopsy has improved, the idea of, well, if we know that there's a relatively small cancer just in one area in the prostate, perhaps we can just treat that area rather than the whole thing. That's the principle behind focal therapy. There are a number of different ways of achieving that. Ultrasound is one of them, high-intensity ultrasound or TULSA are a couple of methods that use ultrasound as a treatment. There are other methods that are out there. There's something called IRE, or irreversible electroporation. Nanoknife is the commercial term for that. There are laser ablation, there's freezing, something called cryoablation. So there's a lot of different potential energy sources that can be used for focal therapy for prostate cancer.
Fantastic. So, on that same note, you've definitely been exposed to a lot of different technologies, and I think especially at such a heavyweight institution like Stanford, you kind of have to make your bets correctly in terms of when you pick a technology to bring it into the hospital, right? So I'm wondering, like, how did you find out about Profound Medical and the Tulsa procedure? Like, what specifically stood out to you at the time that made you say that you wanted to adopt it?
You're right. There's a lot of technologies out there, and we do have to be a bit selective about which ones to go with. And often it's nice to have a couple of different technologies that can be complementary, because there's no one technology that's the best in all situations. So some of the things that were attractive about Tulsa were the ability to do this under MRI guidance. MRI is really our best imaging technology for prostate cancer. It contrasts to ultrasound, which is used for some of the other methods. So the Tulsa procedure is done with patients asleep, laying in the MRI scanner. So the treatment can be monitored and adjusted in real time using some cool MRI technologies that are available. I also have a great relationship with our radiologist. This is a very collaborative type of technology, because the way prostate cancer is typically diagnosed is by a urologist. So we'll do biopsies, we find prostate cancer, and then we'll either treat the patients ourselves or refer them to a radiation oncologist who may do radiation. Tulsa is a little different, or MRI is a little different, in that that's normally in the purview of a diagnostic radiologist. So to really have a good Tulsa program, you have to have the urology side who is making these diagnoses and having the ability to talk to patients about what are all the options that are out there, but also have to have the technical side, the radiologists who have access to the MRI scanner, which is necessary for doing Tulsa. We had experience here with a different MRI-guided technology, and were a key player in a trial that was published 2022 that used a different technology done under MRI guidance and got really good results. So based on my strong relationship with our radiologist colleague, our experience using MRI-guided ablation, and now Tulsa coming along as a great way to treat prostate cancer while still collaborating with the radiologist and using MRI guidance, it was a natural fit for what we do here at Stanford.
That's great. When adopting new technologies, there's always this effect of either, one side complementing, let's say, the workflow that you have in existing technologies. In any ways, did it at least challenge any of the existing protocols that you had?
I mean, any new technology, can be disruptive of the status quo, and that is typically meaning, again, surgery or radiation therapy. I think, we're always striving to find the newest and greatest technologies and to figure out what their appropriate role is to try to reduce side effects of treatment. And all of us who treat patients with prostate cancer do recognize that side effects are a big, big deal and something that we always try to reduce. So I've not met lots of resistance in that space. I mean, I'm a surgeon. I continue to do a lot of robotic prostatectomy operations, even though Tulsa is something that we offer to many patients. So I think finding the right role for these treatments is the tricky part. But we've not had a lot of resistance here, just because by offering new technologies that frequently will bring in more patients who may have heard about a technology and come to see me for this. So we end up being able to see more and more men, some of whom end up being great candidates for Tulsa. Others may go on to have a robotic prostatectomy that I do on them, or end up getting radiation therapy with one of our radiation oncologists.
Yeah, it's good to hear that. I think a lot of people forget that, as a physician, it's not like you're one technology over another. It's really specific to each patient. I'm wondering, when you look at your patient populations, where did you feel like Tulsa was most beneficial based on the patient population? And are there any certain groups of or types of patients and use cases that maybe surprised you that you started to see more of a benefit for?
I've developed a reputation in this area of focal therapy, so I do see a lot of patients who specifically seek me out for image-guided treatment, whether that be with HIFU, which stands for high-intensity focused ultrasound, or in this case, TULSA. So in those patients, when I see them, they're already largely have sold themselves that they're interested in this technology even before I've spoken to them about it. Other patients, I may be telling them about TULSA for the first time, and they've never heard about it before, and so then we send them some reading materials and talk to them about what this treatment looks like and how it might compare to the more conventional treatment options that are out there. So in terms of who is a good candidate for this, TULSA is fairly versatile. So it can be used as a whole prostate treatment. In fact, that's how it got approved as a new technology. They had sponsored a clinical trial called TACT, T-A-C-T, a TACT trial that was published a few years ago. And that was a whole prostate ablation technology. As the idea of focal therapy has become more popular, we have learned that we can apply TULSA to a part of the prostate. So the patients that I like the best for it are for guys who have a cancer that's, say, an intermediate grade prostate cancer. The low grade non-aggressive cancers we think are better off not getting treated and just monitored with an approach called active surveillance. The really high grade, high risk cancers and or the metastatic cancers that have already spread similarly are not great candidates. But the sweet spot for an ablation treatment like TULSA seems to be the intermediate grade cancers. And in particular, those are up towards what I'll call the front side of the prostate or the anterior side of the prostate, which is the farthest away from the rectum, farthest away from the nerves and blood vessels that help with sexual function. TULSA works particularly well for tumors in that location and in guys who may have larger prostates anyways, not because of their cancer, but because of non-cancerous enlargement of the prostate. It can cause a lot of urinary difficulties. So when we treated an anterior tumor, we also get some of the non-cancerous enlargement ablated. And those guys can have not only treat their cancer, but have significant improvements in urinary function afterwards. So those are my favorite to treat, and I think really the ideal scenario for TULSA. Although, again, we are able to treat the whole prostate in guys whose cancer dictate treating more broadly.
Got it. And I'm wondering, one of the things that stood out to me about TULSA when I was first actually at AOA and I was walking around and seeing it is that, it generally has a very, I guess you can call it like completely incision-free therapy because it's MRI guidance and it's going through the urethra. And so that has like very, very minimal impact on consonance and also sexual function. In terms of what you see, how does that live up in practice in comparison to, let's say, other modalities to treating prostate cancer? Because I guess when you do like a radical prostatectomy, that's one of the concerns, right? Is that it's sometimes difficult to avoid having some impact when it comes to like continence or sexual function.
Yeah, you're right. The side effects do end up being a big deal for this. So without question, TULSA is incision free. You're right. We put the urethra applicator or probe is placed through the penis up into the bladder. So it's just using natural holes for delivering the treatment. And as a result, the recovery tends to be quick. These are done as an outpatient procedure. So patients get this done and are able to go home on the same day. So fairly quick recovery process, which is great. The urinary and sexual function side effects are a big deal with conventional treatments for prostate cancer, in particular robotic surgery to remove the prostate, which again is still very widely done and is an excellent treatment for appropriate patients. But risks of urine incontinence can be at least 10%. In terms of long-term recovery of urine control, about 10% will have bothersome incontinence. Erectile dysfunction can be upwards of 50% of guys who, many of whom come in totally normal and never recover that function. So it's something that scares many men away from getting screened or treated in the first place. TULSA, the jury is still out to some degree. We're eagerly awaiting the results of the CAPTAIN trial, which I think we'll talk about here shortly too, which is really a direct comparison between TULSA and prostatectomy. We have treated many men with TULSA who've recovered sexual function and are thrilled with their results, but there are some that still do have erectile dysfunction that they may contend with. In the TACT trial, that number with new erectile dysfunction was somewhere in the neighborhood of 20% at a minimum. And even more would say their function is still good enough for sex much of the time, but certainly deteriorated compared to where it was before. So much of counseling patients about these treatments is setting appropriate expectations. Say, yes, relative to surgery, we're thinking that this will likely have a lower risk of sexual dysfunction. We don't know that definitively yet until this CAPTAIN trial results are published. But keep in mind that there is a significant risk that your function may still be worse, or maybe you weren't taking medicines like a Viagra or Cialis before, but now you're going to have to following treatment. And the locations of tumor in the prostate and how close to the nerve bundles we need to be treating and how aggressively can play some role in the chance of recovering function, as do things like how old is the guy and does he have good or bad function to begin with. Those are also powerful predictors about how things are going to be afterwards.
Got it. Yeah, and on that note, I mean, might as well talk about it now since you mentioned it. Like that was at least when I was reading up in terms of what was publicly available. When I first found out about Profound, and I was reading the CAPTAIN trial, but essentially the CAPTAIN trial showed really good perioperative results. So 0 blood loss, reduced pain, shorter recovery, better function scores compared to, let's say, robotic prostatectomy. So how did these outcomes essentially resonate with your own TULSA experience in the clinic? And again, I know it's comparing like a clinical trial to like your own experience, but I'm wondering like, how does that compare?
Yeah, the main ones that you mentioned some of those are quite obvious and not surprising. So the lack of blood loss, that's universally true with this treatment. You lose some
because
blood.
It's incision free, right?
Yeah, exactly. So we don't have blood loss with TULSA, which is great. I mean, it's better not to lose blood than to lose blood, but losing a few hundred cc's of blood with a robotic surgery, you make it back within a few weeks, and that's not really a long-term thing. So somewhat less meaningful. Similarly, pain afterwards. Anybody who has surgery is going to have some degree of pain. That's not fun to go through, but 2, 3, 4, 5 weeks later, that may be a distant memory and is less important than the permanent or long-term outcomes that we think about. So I'm particularly eagerly awaiting the urinary function, the sexual function, some of the longer-term outcomes, which can be permanent side effects in men who may have robotic surgery done as treatment for their prostate cancer. So the early results that are announced in CAPTAIN are very much in line with my experience and not surprising. And we'll see in a few years now how that directly compares to surgery. That makes it a lot easier to counsel patients so they can really have a direct apples to apples comparison about what's your chance of urine leakage, what's your chance of erectile dysfunction, what's the chance that your cancer is going to be cured and you're not going to go on to need additional treatment.
Sure. And, I'm wondering, like, when you do have patients come in, right, you have to kind of weigh out these options between, like, robotic radical prostatectomy, the TULSA procedure and everything. What are they most curious or skeptical about, in general?
Most men will have the same goal, or say all men have the same goal. They want their cancer to go away and they don't want it to impact the quality of their life or have new side effects. In practice, you often have to give back on one of those things. The more aggressive you are with cancer treatment, the more likely you may be cured, but the more likely you may have side effects. And every guy is a little bit different where that balance lies, what they're willing to put themselves through in an effort to cure their cancer, or how much side effects they're willing to put up with. So that's a big part of those conversations about these treatments is what are the expectations from a cancer standpoint and the side effect standpoint across these different treatments.
Got it. And by the way, for anyone who's listening, who's interested to learn more as a patient, you can go to tulsaprocedure.com. You can learn more there. Something that I'm always interested in, Dr. Sonn, is technology adoption, right? And technology adoption is like particularly unique in medicine because it's very difficult to find, let's say, early adopters or visionaries like yourself who see the value of a technology and is willing to put up, like, let's say, political skin in the game to adopt it and do trials and stuff. I'm wondering, like, when you sit in your vantage point, what do you feel is standing in the way of, let's say, wider adoption of TULSA in, let's say, the academic and the, let's say, rural or community urology clinics today?
Probably the biggest thing is widespread access to MRI. These MRI machines are very expensive, and they're
And
usually
big.
they're very large, very expensive, and they're usually owned and operated by the radiology crew that's at your hospital or facility. And many of these diagnoses are made by urologists who have access to the patients but don't have access to the MRI machines to do these procedures in general. So there's some logistical hurdles that have to be overcome there to figure out, if you have a urologist who has a patient that wants this treatment, okay, well, where are you going to go? Are you going to refer them? Is this something that you're going to try to offer to your patients? Do you have a large group that you could think about getting one of these machines? Or you're going to partner with a radiology practice who is able to do these treatments? Here at Stanford, I'm spoiled and I'm lucky because friends with our radiologists, we're all under the same roof and all working on the same side. That is trying to help the patient to the best of our ability. So that's something that's facilitated my adoption here. But beyond this, in speaking to other urologists, that ends up being the biggest challenge. They may hear about TULSA, they like the results that they've heard about, their patients may be asking them about it, but then there's just the technical side of, how am I going to get this into my hospital, because of the need to loop in the radiologist and have access to the MRI machines for the procedure.
Right. And I think, if you don't mind, for those who are watching and learning about this for the first time, I'm going to bring up a video from Profound's YouTube page. I'm going to press play. Maybe you can kind of give us a play-by-play of what we're seeing here, but this kind of, sort of illustrates what that procedure looks like.
Yeah, the long cylinder that they have there, that is the urethral applicator. That's the thing that goes through the penis and is the source of the ultrasound that shoots from the inside out. It's attached onto a robotic device that's compatible with the robot that's on the outside. And then that can be used to rotate this device physically within the urethra. And that's what we're seeing here. The ultrasound energy is shooting outward from this device, and it's modulated by the MRI machine and this robot to adjust the speed and the power of each of the little elements that shoot out the ultrasound. So you can really customize what temperature that you want to achieve in what area within the prostate, while trying to minimize heating of normal structures that we don't want to image. So that's what this is emphasizing here. You can see these are MRI images, the patient's asleep under anesthesia, laying in the MRI scanner, while the physician's in a control room right nearby, making these adjustments and carefully monitoring the treatment in real time to make sure, again, everything's getting as hot as we want it to, but not too hot. And that we can program in and say, all right, I want to treat the front half of the prostate. I want to treat the right side. I want to treat the whole thing, again, while trying to minimize the risk of damage of structures nearby, like nerves and blood vessels, or the rectum that sits right back behind the prostate. It takes several hours to do the procedure, and then afterwards, the patient comes out of the MRI scanner, the device is removed. Typically, we'll put a catheter in the bladder that stays in there for a week or so to allow the urine a place to drain while we're waiting for any swelling that may have occurred in the prostate to go down. And then the catheter is removed. And once that catheter is out, guys can basically go back to normal activity straight away.
That's fantastic. And then again, for those who are perhaps patients or listening for the very first time, something to point out, maybe Dr. Sonn, you kind of expand on this, is that, with MRI, aside from the imaging quality, it is also, because it's MRI, it's radiation free. So I think that's something that a lot of patients have been always curious about and interested in, but maybe you can expand why, like, the value of doing this via MRI versus, let's say, CT or any other modality.
Yeah, there's several advantages of MRI in this space that really make it the only real feasible technology. So CT, you mentioned specifically, we can see the prostate with CT, but you can't really see anatomy within the prostate that allows you to see where exactly the cancer is located. So MRI does a nice job of showing the soft tissue anatomy inside the prostate to be able to see where is the cancer and how broad of an area do I want to treat to destroy the whole thing. It also gives us the ability to do what's called MRI thermometry, which is basically a thermometer that you have by imaging, so you know how hot the prostate's getting. We know how hot it should get to kill tissue. We don't need to go way above that, but if we're below that, we risk having leftover cancer behind. So MRI allows for the thermometry. You're right, there is no ionizing radiation. So unlike radiation exposure that you might get from lots and lots of CT scans that could potentially even lead to a cancer at some point in the future, there are risks of radiation exposure. We don't see that with MRI. MRI is using magnets, magnetic fields, and doesn't use ionizing radiation, so it's very safe in that regard.
And you mentioned about the thermometry. Like, I think that's really important to point out, and that's what really stood out to me for this kind of procedure. I think for some prostates, you have to just go in and do a radical prostatectomy and remove it. But then if not, you can do really tissue preserving procedures and only get what you have to get out, and not just ablate the entire thing. And that's using MRI, and the TULSA procedure allows you to do that.
It does. And again, TULSA can be used to treat the whole prostate. So if we have, it's common for prostate cancer to be what we call multifocal, so multiple different areas of tumor in the prostate. And if there are multiple areas, some on the right, some on the left, some in the front, some in the back, and all of it which requires treatment, depending on the grade or what the pathologists tell us under the microscope, how that cancer looks, we can treat the whole thing. Or frequently there may just be one area that we're worried about, and then we have the ability to customize that treatment to really get that balance of cancer control versus side effects. And every man is a little different again. So this is a conversation of, okay, how aggressive are we going to be with this treatment? Do we want to err on the side of treating a broader area, perhaps with somewhat more side effects, or do we really want to focus in on the cancer? And there's no necessarily right answer. This is why these are long conversations with patients to really figure out what are their values and how do we personalize this care based on the particular preferences of an individual man.
That's fantastic. Yeah, and I think what's most exciting as we kind of progress in society with new technologies is that now physicians, instead of having like one modality to treat a disease, you have multiple approaches, and you can kind of custom fit that based on the patient population and get the best outcome, period, which I think is really exciting. You mentioned the CAPTAIN trial earlier. I want to mention this to the physicians who are listening. You can go to profoundmedical.com/CAPTAIN, CAPTAIN -trial to learn more. But I'm wondering, Stanford being a really data-driven institution, are there any future trials or ongoing trials or patient registries or anything that you're looking forward to coming out?
Yeah, let's talk about CAPTAIN a little bit, just because I think it really is, it's kind of a landmark trial. So this is a 201, or the initial plan was 201 patients, randomized trial across multiple centers in the US, Canada, and there's one in Europe. It just recently finished accruing patients, meaning everybody has been enrolled and treated. It's going to take a number of years to get the results that come out, because whenever we have a cancer trial, we want to know not necessarily how you're doing 6 months after the treatment. We want to know how you're doing 5 years, 10 years, 15 years, even 20 years down the line, in particular with prostate cancer, where the outcomes do tend to be measured sometimes in the order of decades. So a randomized trial is one where a patient will come in and will sign up for a treatment not knowing, when they consent to participate in the trial, are they going to be getting a prostatectomy, or are they going to be getting TULSA in this case? And that's what's so challenging about doing these trials, because there are many people who say, well, I don't want to be randomized. I want to choose which of these treatments is going to be, that I think is going to be the best for me. So it's really a big accomplishment that I applaud Profound for putting their money where the mouth is. These are expensive trials to support. And then a big accomplishment to shepherd this through there, to get the sites that are on board, to have physicians who are leading at each site, who's willing to have these conversations and can present it in a way where patients understand, we don't know the answer to this question. We don't know whether surgery is better than TULSA. it's not considered an ethical randomized trial if you already are certain of the answer and you're providing somebody an inferior treatment. So we don't know the answer. But many times patients will have their biases going in. So it can be difficult to accrue to trials like this. In fact, the conventional wisdom had really been, this is impossible. There have been many trials before that were closed way early because they get nowhere near to treating the number of people that are necessary to answer the question. So I applaud Profound for sponsoring this trial, and it's really a big achievement to have recruited all these patients, and now we get to reap the benefit of this in a few years to truly know what is the difference in the cancer control, what proportion of people, if you have surgery or TULSA, are going to go on to need additional treatment, and how do you have an apples to apples comparison of what are the odds of needing to wear a pad for urine leakage, or what are the chances that you're going to preserve that sexual function. So the Captain trial, again, we're not accruing to it anymore. All the patients are on the study, but we will continue to follow up those patients for years to come to know how they're doing. So that work is ongoing here at Stanford. We also do keep a registry of patients who are treated with TULSA or HIFU or some of these other ablation methods, so that not in a formal trial, but we are getting outcomes information, cancer outcomes and side effects in all the patients that we treat over time, so that we can publish that work, and also that I can tell my future patients, based on my experience in 100 patients, 200 patients, 500 patients, this is your chance of having X, Y, or Z outcome.
Yeah, I'm glad you mentioned that. And also, it's important for a lot of people to understand that those are some of the limitations. I think, ideally, do you feel like, after a certain amount of studies are done and everything, that would you say that, is there a world where patients start out with a TULSA procedure, see how they respond to it first before, let's say, going on to something that's a little bit more invasive and more like a radical prostatectomy? Is that the best way to look at it? Like, I'm wondering, is there a world where you go with a TULSA procedure first before going on to like try surgery?
There is, yes, and many men do come in with that idea of, well, I know my cancer is a little bit too bad to not do anything, but I'm not ready to have my whole prostate removed. Is there a middle ground? So many patients will see TULSA, HIFU, or some of these other focal technologies as that middle ground, with the idea that if it works and they don't have too much in the way of side effects, terrific, they win. But conversely, after any treatment, including surgery, including radiation, there is some chance of recurrence of that cancer coming back. And then we want to know what backup options do we have available to us if cancer does recur. So yes, many of the men that I treat with focal therapy are doing so with the idea that if cancer comes back, then they may be willing to have a different treatment. And that could be doing, in this case, TULSA again. That's part of some of these trial protocols that would allow you to do a second session. Because we're heating with ultrasound, there's nothing that's inherently unsafe about retreating somebody with the same technology. Or if we think it's just not going to work, or we think they're not a good candidate for that treatment, surgery remains an option, radiation therapy remain options. Those were some of the backup treatments that were offered to patients in that TACT trial that, again, got TULSA approved in the first place. So you're right. There is that world where we could try an ablation method first, and if it doesn't work, then turn to the conventional treatments. An important question becomes, well, is the surgery going to be more difficult then in someone who's already had an ablation? And there are publications that come out and that report on, well, what are the results if surgery is done after these treatments? So I've done a handful of prostatectomies in men after HIFU. It is a little bit harder, but it's still very doable. And in my experience, the results have still been quite good.
That's fantastic. And yeah, I think also, just on the tech side, I know like one of the limiting factors is, you do have to have access to an MRI suite. There's a lot of interesting companies out there that are trying to make the MRI smaller. There's one company out there that has one mainly in the, I think, trauma unit that's like a mobile MRI. But hopefully, like, these kind of modalities will lend themselves to like better partnerships for Profound, and then you can have that technology available across the board. Last thing is that anything else you're excited about, coming out from Profound Medical for the coming year or so?
I mean, I don't work for Profound, so I'm not privy to some of the information about what their strategy may be as a company. I think the things that are most interesting for me is to continue to, one, waiting for the results of Captain, two, continue to learn and to push the envelope from other users that are using TULSA to do an even better job of selecting the best patients, and what are some tips and tricks to get us even better results, because that's what all of us are in this for.
I'm curious about that because I'm a procedure guy, so I love hearing about that. But before as we kind of wrap up, I'm wondering, like, have you met with like other users, and like procedurally, what kind of like tips and tricks have you guys shared with each other? Like, anything interesting?
Yeah, there are. I mean, so just as an example, one of the major causes of failure that was identified intact was calcifications, or little stone material that can form in the prostate that many men have, that normally
as a byproduct of the cancer.
No, it's just there.
Oh.
And so normally it doesn't matter at all, and none of us would have any idea, do I have any of this in here or not? It doesn't cause symptoms, doesn't cause problems, doesn't seem to be associated with anything, but it can get in the way of ultrasound treatment. So there are some guys who have bulky calcifications in their prostate that we have to tell them, I know you're interested in TULSA, but this isn't going to be a good option for you, because that, essentially think of it as a stone or a rock, is just going to block the ultrasound from getting where we want it to go. So that's one thing that's been learned, and I think that will continue to improve outcomes as we realize, this is one of the major sources of failure. We need to do something else in this particular patient's case. There's also something else that we've recently started to do when we're treating back towards the rectum. One of the most feared side effects of ablative treatments like HIFU or TULSA is, might you injure or make a hole in the rectum? Now, fortunately, those are very, very rare nowadays, but it's still possible. And the challenge is the cancers are often only a few millimeters away, if that, from the wall of the rectum. And how do you get cancer really, really hot enough to kill it while not injuring at all a very important structure that's right next to that? And so during the treatment, there's a device that's placed in the rectum to keep the wall cool, and that helps. But to try to further augment that, we've started to place another material, something called Barrigel, that physically moves the prostate and the rectum away from each other, so that we have to worry a little bit less about getting heat in that rectal wall. And that's been something that our radiologists in doing the procedures have been very happy with. And that's something that we learned from some colleagues at UT Southwestern in Dallas who also do a lot of TULSA. They mentioned that they've been doing that, so we started to adopt that and have been happy with it. So that's a nice example of a specific technique of a product that was initially used and still continues to be mostly used in the radiation world to try to reduce rectal side effects from radiation, but can be adopted to help us with TULSA to try to keep our risks as low as possible.
That's fantastic. I love hearing that, just because, even though it's 2025, there is this combination of both art and science and medicine. So hearing that, you adopt new technologies, but then there's nuances to how you use them and get the best outcomes is really cool to hear. So,
exactly.
Well, fantastic. Well, Dr. Sonn, I want to thank you so much for coming on the show. For those who are listening, if you're a patient, go to tulsaprocedure.com to learn more. As a physician, you, of course, go to Profound Medical's website, profoundmedical.com. The Captain trial, though, is profoundmedical.com/captain-trial, or just type in Profound Captain trial in Google and you'll find it. So, as always, I'm your host, Omar Khateeb. If you enjoyed this, a urologist or somebody who's in the oncology space will enjoy this, forward this on to them. If you know a patient, of course, forward it on to them as well. And we'll see you all next time. Thanks for checking out this episode. If you want to do me a big favor and join so many other people who have helped grow this podcast, take a second and look below. If you're on Apple, give us 5 stars and write a short review. If you're on Spotify, just give us 5 stars. And if you're on YouTube, hit the like button. And most importantly, if you can, subscribe. We release so many different episodes that you may miss. Be sure to subscribe and turn your notifications on. You get extra points with me if you subscribe across all 3 channels. Thank you so much. And if you felt like this this episode helped you, send this to somebody who'd really enjoy and appreciate it. Share and spread the love. We'll see you all next time.